Hello and welcome to this breakout session sponsored and supported by CSI. And we're going to focus in the next 40 minutes or so on how to deal with calcified lesions. And we have seen, we just came out of the live case from Rotterdam on calcific disease. We had another challenging case yesterday. So this is an entity that we see more and more often, and we are gathering more and more techniques on how to treat these lesions and how to prepare for an optimal PCI procedure. In the next 40 minutes, we're going to focus on orbital atherectomy, which is a new kid on the block, at least for European physicians like myself, but there is already quite some data and also experience in the United States. And who better to introduce and get us educated on this new technology than RJ Courtenay, who is also the leading principal investigator of the Eclipse randomized trial. So with that, RJ, thank you very much for joining me in this breakout session. The floor is yours.
I think it'll be an interesting discussion. It's unusual for us here in the United States to be able to teach you in Europe about what we've learned, because it's usually the other way around with all of these technologies. So I look forward to the opportunity, and we'll talk about some insights as a whole. I think just framing the problem, we saw two great cases at this meeting, but sometimes we don't see things going that smoothly, and we see things like this case, which is basically an underexpanded stent in an LAD, and this was deployed, it was underexpanded, patient came back, actually had rotational atherectomy and still had an underexpanded stent. Imaging catheters wouldn't cross, balloons wouldn't cross, finally a 125 balloon had to cross to make way. Two different companies, NC balloons wouldn't cross. And the question is, why did this happen? Now, there are treatment modalities that can solve this problem, but the best thing for the patient is to avoid that problem from happening in the first place. If you could prep the lesion adequately, then you wouldn't need this to actually have to happen. And so the question really is, are we prepping lesions adequately in 2021? We certainly have tools to do it, but I think given the numbers of cases that we get and others get at referral centers for underexpanded stents, there is a gap here, and there's an unmet need for adequate lesion preparation. Now, the reason for good lesion preparation is twofold. It's not just to be able to get your stent to where it needs to go. And I remember as a fellow, initially I used to think that we would use atherectomy, for instance, to just be able to deliver stents. But the reality is delivering a stent and then not having it expand is a worse problem than actually not being able to deliver the stent at all. And so in several ways, a device like an atherectomy device would actually be able to modify the plaque and then facilitate procedural success safely without further complications and pain and suffering during the case. Now, why do you have to prep lesions appropriately for calcium? Well, the reason is because calcium is basically a rock in the vessel, and it impairs the ability of the vessel to expand, and it impairs the availability of drug, and also the ability to get stents to where you need to get them. And these are just some pictures of what can happen: abrasion of polymers, stent being stripped, underexpansion, and a big problem that way. Now, in terms of expansion of stents within calcified lesions themselves, it's a really simple principle. If you have a concrete wall that's inside your stent, then when you put a stent in and blow it up, it's not going to expand. It just gets restricted by that wall. And the more circumferential the calcium is, the more thick the calcium or severe it is, you're going to see less and less expansion of your stent. And that's why calcium modification strategies are important. What are the tools we have? We have many. We actually have balloon-based devices. We have devices that are modified balloons. We have lithotripsy. We have laser. We have different types of atherectomy. And the question is, when should you use what? And that's part of what we're going to talk a little bit about today. Now, irrespective of the device you use, one of the mechanisms of expansion of stents is the ability to generate a fracture. We saw this on the case yesterday from St. Francis. There are other ways to look at this besides OCT, but perhaps OCT has the best resolution to be able to show this. And in this slide here at 6 o'clock after calcium modification, you see a fracture, and that has been associated with increased expansion and actually less TLR for patients that actually get a fracture after you modify the lesion. Now, our group, in collaboration with St. Francis and the CRF Core Lab, has actually looked at this, and the idea here is to generate a calcium score based upon the arc of calcium, the thickness of calcium, and the length of calcium that can then predict whether you're going to be able to get a fracture and whether you're going to be able to expand the stent, and similarly whether you're going to need to use a calcium modification strategy more than just a standard balloon. And basically, if you have more than 5 millimeters, if you have more than 0.5 millimeters of thickness, and if you have more than 180 degrees, you're going to typically need a special strategy to deal with the coronary calcification. Now, what is the CSI device? The Diamondback 360 on the coronary side, because it also comes in a peripheral construct, is a simple device. You can do it through 6 French. It has a motor. It's an electrified motor device that comes on a pole that can be wheeled in, and it is an over-the-wire based system that allows you to modify calcification. Now, the wire for this device initially was a much stiffer wire, but with the advent of this flex tip wire, honestly, it makes a big difference. This is a wire that you can primarily wire many lesions with. It actually doesn't get dinged up at the distal tip. You can reshape it in many ways. And for many cases, this is a very, very facile wire, and it doesn't require a wire exchange, which is pretty important. We do tend to exchange it out after we do the atherectomy because it is more floppy than other wires, and it's also long. But at least for the initial wiring and even wiring multiple branches, one often typically does not need to exchange it. The way OAS works is it's basically differential sanding. So similar to rotoblader, you'll get sanding of calcified segments, non-sanding of non-calcified segments if there's no wire bias in that area. And it also orbits in the vessel, which is why you only need one device, this 125 device, in order to effectively get atherectomy across a large variety of vessel diameters. Now, because the device goes back and forth in the vessel, and also because it's rotating eccentrically, you also get some pulsatile forces on the vessel wall. The measurement of those forces remains to be determined, but there is cracking force that you get even if the vessel is concentrically calcified and you haven't done superficial abrasion alone. You'll get both together. And so in a sense, you get a combination of atherectomy, also calcium modification through the pulsatile forces, and as I said before, a single device will affect all of this. Now, one question that always comes up is, does the device cross? Because it doesn't have a front-cutting burr on the end of it. Now, there was an iterated version of this that did have it, but it turns out that for many cases, in fact, the vast majority of cases, you actually don't need it, because by rotation alone, and especially at the speeds that this device rotates at, you are able to cross lesions that, frankly, I personally thought might not cross based upon this device, but in many respects, it actually does. And so it's very useful for devices where balloons won't cross or even microcatheters won't cross, and I'll show you a case of that in a second. These are sort of comparative data or comparative schematic looking at the various types of plaque modification out there. And I think the sweet spot that OAS can fit in is one where you actually need to get across a severely calcified lesion, but then you don't have to use a second device to be able to attain calcium fracture and larger lumens after you do NC balloon followed by after the orbital atherectomy. So the other area where I think this device does shine is in eccentric calcium or calcified nodules. This is just an example of what it looks like in the distal left main. On IVUS and OCT, there's a characteristic appearance. And this idea of a calcified nodule is one that people have seen historically, but actually occurs more frequently than we would like to think. Here are some data looking at prevalence of calcified nodules and severe calcification, and it happens quite frequently. And so if you suspect it, this is where a device that's an atherectomy device probably has the most promise compared to any other device out there, because it will shave that calcified nodule as opposed to other devices that just try to make concentric type fractures. Now, in terms of deep calcium modification and eccentric calcium, this is a paper that we published, again from St. Francis, collaborating with CRF in Columbia. And what you basically show is that you will get modification with this OAS device that effectively gets modification of thick calcium and gets you a larger lumen even when it's eccentric. So that's another facet of the device too. Now, in terms of the outcomes, this was the Orbit 2 trial, which was done almost a decade ago, and basically showed that the rate of adverse events with this device in that trial was, or that single-arm study, was quite low as a whole. The angiographic complication rate was also low, but if one looks at the perforation rate of 1.8%, this might give people pause. Now, remember, this was when we had only the original wire, not the floppier wire, and I do think that there was some learning that we needed to take place from even that experience to what we do now. And as that example of that, I'll just show you. This is a case where you have a really, really retroflex circumflex. There is severe calcification there. And the question is, just up front, to experienced European users, would you do atherectomy of this lesion? Remember, it's going to be hard to cross with anything in this case, but would you do atherectomy of this lesion? Now, this is what happened after wiring, and the wire bias is basically illustrated with this dotted line. And again, I'll ask the question, would you do atherectomy of this lesion, spinning any device down really, really rapidly to abrade calcium? I think the intuitive answer to that is no, because there's severe tortuosity, the wire has straightened the vessel, and even if you believe in differential sanding, it wouldn't make sense to do this. And so in this particular case, basically the operator did do it early in the learning experience, and there was a perforation which was fortunately sealed. But I would posit that this is very, very predictable. And just by looking at the angiogram alone, I would say don't do it in that particular case. And so I think with those types of learnings comes modification, not of technique, but just of when you would use a specific device. And Nurat Behar, who's actually a Columbia affiliate down at Miami Mount Sinai, published data and presented at TCT this past year looking at 519 patients and really showed that the rate of perforation was much lower than seen, at least compared to historical controls. The rate of other angiographic complications were low. And I think this reflects sensible practice of the use of an atherectomy device. I don't view this as like a learning curve. I view this as almost a training thing where you see that type of lesion I showed you and you just say, look, we're not going to do it in that particular case. So I'll just end with one case that illustrates, I think, the advantages of this device. This was a case done with 6 French access, snuff box. There's a tight left main lesion. The LED is grafted. There's a tight lesion in the obtuse marginal branch as well. The lower obtuse marginal is actually grafted, but there's intervening disease, so the graft, which is shown here, doesn't actually supply that upper obtuse marginal branch. So the question here is, how do you treat the serial disease? You want something to treat the left main, you want something to be able to treat the distal lesion. Now that distal lesion looks like it's a relatively smallish vessel, and so some may say, well, we don't want to use atherectomy. And I would agree with that, except when we tried to actually treat this, we ran into a few hurdles. First is we couldn't get the IVUS to cross into the obtuse marginal despite wiring it successfully. You can see how much calcium there is overall in the vessel. But more importantly, a microcatheter actually wouldn't even cross down that distal area. And this is done, I did this case, so I was spinning the microcatheter, typical CTO technique, and it would not cross. Now maybe that's because it was getting hung up proximally, but either way, if you can't cross with a microcatheter, that's going to be a strategy where you're going to need to think about using atherectomy. And so in this particular case, I actually wedged the microcatheter and crossed with a Viper wire, essentially primarily. One can think about how, like for instance, a roto wire, a stainless steel wire might act in that type of vessel. You're never going to be able to torque it down distally. The good news is roto now has a new wire called the drive wire, but at least with the Viper, this was able to be navigated distally and successfully crossed. Now the strategy of OAS here was going to be to manipulate the advantages of the device to my advantage. And so what that meant is, because the left main is big and we're using a 125 device, was going to spin through that at low and high speed. I didn't want to atherectomize the intervening vessel, so we'll glide assist 5,000 RPMs. It's a slower speed than Dynaglide, and it actually is able to be done with the brake down or up, so you can advance the device through there and then do your distal low run and be very gentle with that run because of the vessel size. And so after atherectomy, which was done very, very slowly, remember the technique is not this pecking rotoblader technique, it's a slow going through the vessel technique, and then ablating on the way back. That's what it looked like. And then the rest really becomes basically PCI. So you exchange for a wiggle wire, pre-dilate, always want to pre-dilate with an NC balloon after atherectomy. We dilated further. This is what it looked like after balloon, where you can see there's effective plaque modification and expansion. We then deploy a stent in that circumflex into the OM, a 3.0 stent. We then deployed a fluoro stent, post-dilated to 5.0, and then finish with a final IVUS, which shows concentric expansion, good lumen areas, no distal dissection. Everything looks good. I'm not going to show you the whole run for the interest of time, but this was the final angiogram that was effectively achieved. So in conclusion, what can we learn about calcium modification today, and where does OAS fit in? I think number one, coronary calcification is far more common now in the cath lab than it used to be, say, 10 years ago. This is perhaps due to an aging population, more comorbidities, people coming to the cath lab with them, people not undergoing surgery sometimes if they don't wish it or the heart team declines them, and then also downstream presentations. It's very rare now to see type A lesions. We're seeing patients that have CKD, multivessel disease, and calcium is ubiquitous in those types of circumstances. Remember, calcified lesions are among the highest risk lesions we treat. There is more short-term pain, suffering, and also risk of causing problems with balloons, atherectomy, or anything for that matter. And long-term outcomes, they're among the highest rates of restenosis and thrombosis that we see. So what do we do with it? Well, I think I would first say that I think imaging is a must. The reason for it is it can help you diagnose calcium. It can help delineate where the calcium is, superficial, deep, eccentric, nodular, and otherwise. It allows you to pick your treatment strategy according to what you see. It then also allows you to optimize the stents after you treat so as to be sure that you're getting the best result for the patient. The field of adjunctive therapies for calcific lesions, as we all know, is heating up. New device approvals and the like, new trials really are going to drive this field forward, especially as we see more and more cases. And Nicholas mentioned the Eclipse trial. This is just a schematic of it. Basically, we're almost 3/4 through enrollment of 2,000 patients, randomized to an OAS-based strategy versus a balloon-based strategy, followed by DES. There's a 500-patient arm of OCT to look at the mechanism of what happens as well. And we're really looking at clinical outcomes here, because I think personally that we're not doing enough to treat calcified coronary lesions with conventional technologies, and it behooves us to prove in a randomized fashion with high-level evidence that we can really change outcomes for patients with a strategy such as OAS. So with that, I'll conclude and I'll leave some time for discussion and for Nicholas as well, who has great experience now after having been using this device in Europe.
Thank you very much, RJ, for this valuable, instructive, and balanced educational talk. Let's first see what kind of audience is joining us. So can we pull up the first poll question? And the first poll question is, how familiar are you with orbital atherectomy? Very familiar, somewhat familiar, acquainted, or no knowledge at all? So we'll get back to the results of the poll in a second. But then my first question for you, RJ, because you of course have a lot of experience using the device also, and we have been working with this device for the last 2 months. So you have this forward and backward treatment opportunity, basically. And this is very different from rotational atherectomy. How can that be an advantage?
You know, I think the great thing about it is that when you do your run, you can stop almost in the middle of the lesion. You can, for instance, use the backward if you want to use high speed only on the backward approach, so there's no jumping or anything that goes forward. It just gives you a level of flexibility, and the likelihood of the device getting stuck is exceedingly low. Now, there are going to be people who will say, I've never gotten the CSI device stuck. That's actually not true. I personally have gotten it stuck. But it really is not a concern the way it is with rotablator, for instance, where you have to be concerned about something jumping forward and not being able to get it back. And again, as I said, because the device diameter is so narrow, we can actually go into a lesion, stop in the lesion, and there's still typically flow, not only native flow, but also the flush rate of this device is a lot higher than other devices. And so there's active flow going on at all times.
So can you elaborate a little bit on this concept that you can stop in a lesion? Because that is completely counterintuitive from other atherectomy perspectives. Because that would be basically a risk for getting stuck in the lesion. Or am I wrong here?
Yeah, I missed the beginning part. Say that one more time.
So it's counterintuitive for somebody who is experienced with rotational atherectomy to basically stop in the lesion. You are always, I mean, common learning is that you always pull back until you are in a more healthy segment of the vessel. Otherwise, you are at risk for getting stuck in the lesion and, yeah, you're in trouble.
Yeah, I mean, look, I still, if it's super tight in that area, I will pull it back. But especially when you get to the end of a long run, you can, as for a long layer of calcium, stop in the lesion, and there really is little untoward side effects. The other part that I would mention with this device is because the flow rate is high, also because of the fact that the diameter is smaller, the incidence of no reflow, the incidence of bad ST elevation, and I would even say pacemaker, for instance. And remember, these things you really need to study in a randomized fashion to truly understand it. But there is enough evidence with this device now that the likelihood of those things occurring seems to be very much lower than, at least in my impression, from the rotablator type of experience. But again, I caution a little bit in this regard. We actually have run a study at Columbia looking at microcirculature, which does indirectly support what I'm saying. So that's kind of why I'm comfortable saying that at this point. But I think it's a little bit different from the devices that we are used to using, and it may be because of the diameter, and it may also be because of the flush rate, which I'm sure when you plugged it in for the first time, you noticed how much flow was going through that device compared to, for instance, a rotablator.
Yeah. So by the way, you are in New York, I'm in Rotterdam, and we are in the same studio. It's kind of cool. Another question that popped up is how to treat osteolesions, right? So a potential strategy is to glide assist your way beyond the lesion and then pull back. Is that your approach of an osteolesion with orbital atherectomy?
Yeah, I mean, remember, initially, osteolesions are contraindicated, and the reason for that, I really want to caution people, is that if you go full speed spinning in, you're going from a very large orbit that's unconstrained in the aorta to a smaller one in the left main or in the right coronary, for instance. And so that can lead to a dissection, particularly if you're not coaxial. So you don't want to do that. But because of this glide assist feature, which manipulates this ability to spin to get through a lesion, you can glide assist forward and then do the ostium on the way back. And so, for instance, for like a calcified nodule in the left main, I have a case of this on Monday that I'll be doing. It's the perfect device for this because I worry less about having to truly set up the coaxiality of the guide, the wire, and everything, because I have to typically, under ordinary circumstances without OAS, spin on the way in, and you really don't want to, even with a rotablator, come at a different axis or something else because that can cause problems.
Yeah. So in your opinion and in your experience, glide assist is safe to go through a lesion and then come back with a treatment modality at 50,000 RPMs or 80,000?
Yeah, I mean, I do think so. There are certain cases, though, where the vessel is going to be so tight that you can't get in using glide assist. That's rare, but it certainly can happen. If that happens, then the options, the bailout options, would be to do a small balloon inflation to make room or to use rotablator in that circumstance. But I think that for the majority of cases, it actually is a very nice technique, off-label, of course, but can be used and can be used successfully.
What about this feature of at highest speed? When would you explore that? During the live case, Roxana and Azim were mentioning, in larger vessels, you may want to explore that feature. What is your take on that?
Yeah, I think large vessels, straighter segments, those are where you want to use it. I would caution anybody from doing high speed around the ostium of the circumflex from the left main, for instance. But certainly, a large vessel like a left main, big RCA where there's not a lot of tortuosity, that's a place where I would do it. I personally, do it. Typically, I'll go low speed forward and high speed back, just to avoid any jumping or things like that from happening, but there are different modifications. I know there are operators who predominantly use low speed for everything, then they'll do an NC balloon, and if they get fracture, then they're good to go. There are other operators who feel pretty comfortable using it. But I would caution people from using high speed every time in every vessel. I don't think that's the right technique at all. In fact, low speed tends to get the job done for most cases. We have a question from our audience in terms of reimbursement issues that are at stake or at play in different countries. So given those potential issues, would there be indications that you would say never use rota, go for orbital, or are they totally overlapping, the indications for orbital and rotational atherectomy? I don't think they're totally overlapping, and there's, some cases where, you know, if you're really worried about the burr getting stuck, then I would say, you know, never use rota in those circumstances. If you see a vessel where the lumen is larger to start off with, that you're only going to be able to touch it, for instance, with a 2.0 burr, then that's a case where, you know, you might be able to use orbital. You're not going to get to 2.0, but because of wire bias issues in the orbit, you may be able to modify the plaque. So my sense is that there are a variety of ways that this can be parsed out. I personally like having all the tools at my disposal in the lab, whether that's NC balloons, you know, cutting balloons, shockwave, orbital, rota, because I can tend to titrate the therapy to the specific patient that I'm treating. And that was, I think, shown nicely in the demonstration from St. Francis yesterday, where the imaging, and also your case, Nick, where when you sort of looked at the imaging and you made a decision of what tool to treat based upon what you saw on the imaging. I really feel that that's kind of the future for how these technologies are going to need to be used, and it means that we need to do more imaging, but that's okay. I think that we're all in favor of that as a whole, particularly for complex disease.
What is the relative percentage of invasive imaging used in your atherectomy cases?
You know, for us, we tend to use imaging in 80 to 90% of cases overall. For complex cases, we use it ubiquitously. Now, the challenge that I think is out there for most operators, besides cost, is that the most common catheter that's used for imaging is the Eagle Eye catheter from Volcano. And remember, that catheter is not going to cross many of the cases that you need to use atherectomy in. So that becomes an impediment to others. We're fortunate in our institution where we have the newest OCT catheter, we have even HD IVUS catheters like the one you showed yesterday, which are much, much smaller in terms of their crossing profile. So that makes it much more easy and facile to use those catheters. Similarly, the HD component enables the pictures to be easier to read too. So my feeling is that if you're going to be treating a lot of calcium, generally speaking, you're going to evolve in the use of your catheters unless you're only planning on doing post-stent imaging.
Another question from the audience. If you have this phenotype with a very tortuous calcific disease and quite diseased and obstructive, what would be your go-to device? Is it a smaller, a 125 burr, or is it a diamond bag?
Yeah, for me, if it's really tortuous and calcified, that's probably the one area where I would really favor rotablator over OAS. And that's okay. It's, I think, fine to use what the patient needs. And even with a 125 burr, as we all know, that can also be dangerous. So you just have to be really careful. And it's just, when you look at the angiogram, what I also recommend people to do is when they cross with the wire, whatever wire that is, the rotowire or the OAS wire, if as long as the kidney function is okay, take a cine angiogram with contrast to see where the wire bias lies. Because that, in some cases, will say, okay, I really shouldn't be doing atherectomy. In other cases, it'll say, okay, these are going to be problem segments, and I need to be really careful in those problem segments. And that's how you avoid complications as a whole.
So another question. So there are very practical questions coming in from the audience, so thank you very much for that. How safe, Ajay, is the use of orbital atherectomy in calcific neoatherosclerosis in a stent? Is it safe to use orbital?
So totally off-label, and you know, but there is a published experience on the use of OAS in calcified or in-stent restenosis. And in general, I think as long as you do it slowly, as long as you're watching carefully, we've done it in our lab, and it seems to work pretty well. Also because of the fact that it does orbit. But in order to make that diagnosis, you need to do imaging up front. But once you do the imaging and you see that, it's definitely a tool that can be used.
Another question on nodular calcium. Is there a difference between rota and orbital? I can already give you my opinion. I don't think there will be a difference in approaching nodular calcium. I do believe that IVL would be the less better option. So I would prefer rota or orbital over intravascular lithotripsy. What is your take, Ajay?
We're actually looking at this. I think it needs to be studied. There could be a theoretical advantage because of the fact that the OAS orbits, but that might be negated if the wire bias with a rota aligns you right along where the nodular calcium is. And so I think that's one of the reasons why you need to study it. For me, though, I tend to like the device because, as I'm a radialist, it's 6 French, it's pretty easy to use, and I like the use of the wire. So that's just a personal preference thing.
Yeah. Is there any health economic data available on the use of these atherectomy devices? And again, my take would be, well, indirectly there is, of course, because once you have the issue of underexpanded and underdeployed stents, patients will get a lot of medical attention and rehospitalization. So I would assume there is.
Yeah, I'm not an expert in that area, so I don't know of the data right now at present, but what I can tell you is in ECLIPSE this is being studied, and it's a head-to-head randomized comparison. The challenge I have personally with any data that's out there that is single-arm and non-comparative is that you just don't know, was there evolution of practice, were the sites the same, you know, all these factors that can factor into what complication rates, what success rates might be. I do think that all of the companies sometimes will tout their own data from single center registries, and I even showed some single center data as well. But I really would caution people from making comparative statements regarding that, and that's the whole reason that we're doing a trial like ECLIPSE, is to be able to truly randomize, hopefully apples to apples comparison, to see what we're dealing with at that time.
Yeah, well, I think we have time for yet another poll, but I would like to see the results of the first poll. But the second poll is, and of course the folks at CSI would also be interested, based on now what you've heard in the last 40 minutes or so, how likely is your hospital to adopt orbital atherectomy? And I do hope we can see the results of the first poll as well. Can you also use, by the way, these devices through a guide extension?
Yeah, and that's one of the advantages of this one, is that you can, certainly with a 7 French catheter and a guide extension, there's no issues at all. The 6 French can also be done, but you have to sort of, depending on the orientation, you might need to load it outside or just be careful as it's coming in. But yes, it's compatible in that way, which is great because you can use it with a relatively small sheath size. The other thing that I think I made the point of during my case presentation is that irrespective of the vessel size, you can use this device. So one of the things, and I'd been talking to you, Nicholas, about this, is that the concept of doing, for instance, rota with shockwave is, it sounds cool, rota shock, but it's pretty pricey. And so the question is if you were able to get the device down by using an orbital and then using the larger lumen of the same device, that's an interesting concept, and again, needs to be studied head to head to really sort that out. But I think sites like yours might be able to do that study quite effectively.
Okay, so let's look at the results of the poll. Can we bring up the first? So how familiar was the audience? They were acquainted in 60%, but only the 12% were very familiar. So I think this alludes to the fact that most of our spectators, at least, are outside of the United States probably, but also it also shows you that folks who are very interested in this novel technology. And what about the second poll question? Would the hospital consider acquiring this technology and put this technology on the shelf? Can we see the results of that poll? Unsure in 44%, and I think this is also we are living in this pandemic. It's very difficult to oversee future investments, but 17% definitely, and 16% very likely. So I think there is quite a market and quite a need, I would say, for additional technologies to treat these calcified lesions. With that said, you still have all these devices on the shelf, Ajay, or would you be more selective if you would be the director of, let's say, a peripheral non-academic center?
Look, I think that the challenge with hospital procurement is that it comes down to many factors. It comes down, of course, to patient factors. You want to be able to have the tools you need to treat the patients that need to be treated. I think it'd be terrible if you needed a specific tool and you didn't have it at your disposal because of a financial decision. So the real question is does there added value to any particular device or product? But on the other hand, if there is relative clinical equivalence or you feel comfortable using various devices and you have a good track record and you're very comfortable and safe with it, then do you bring in another device that a significant premium without potential reimbursement and that sort of thing? And that's where the decisions become challenging. My feeling, though, as a clinician, as always, and I like wearing that hat when making these discussions because I don't know all the ramifications at people's individual hospitals, but as a clinician, I want every tool at my disposal, and I do think there are unique attributes and advantages of all the tools out there for calcium management, especially given the fact that this is becoming more and more prevalent. We're seeing it more and more often. And there are many subsets. There's the nodular calcium, there's concentric, there's in-stent. There's so many different sort of subtle differences between these. It's not a one-size-fits-all approach. And that's why, for me, you know, when CSI came out, we initially were somewhat reluctant to actually bring it into our cath lab because of the cost premium. But then over time, with negotiations and with the clinical need and indications, we eventually did bring it in. The same thing is true with Shockwave, which currently in the United States doesn't have a reimbursement specific to the device. So we tend to use all the devices at our disposal to treat the patients in the best way that they can be treated.
Ajay, that was a great conclusion to an excellent breakout session. I learned a lot. I hope also the audience experienced or got some experience from it. I thank CSI for supporting this breakout session. I thank you for your expert opinion and also insights. And we have one more hour left at TIO. Thank you all very much. Let's stay in touch. Bye.